Я всіх дуже рада вітати. Я сподіваюся, що тут багато людей, які були з нами в нашій першій серії, яка була дуже продуктивною, і ми дуже вдячні професору Йоргу Фегерту за неї. Я всім нагадую, що це наш проєкт, який ми робимо разом з Європейською асоціацією дитячої та підліткової психіатрії. Ми все це організовуємо разом з Координаційним центром Кабінету Міністрів України, який займається програмою «Ти як?» стосовно психічного, ментального здоров'я. Пані Оксани з нами сьогодні нема ввечері, але завжди вона відкриває. Сьогодні просто в неї такі обставини, що вона не може. Ми все це робимо разом з Міністерством охорони здоров'я України і з Національною службою здоров'я України. Далі не буду вас затримувати і одразу передаю слово професору Йоргу Фегерту, завдяки якому ми взагалі маємо всі ці можливості. Прошу, Йорг.
Thank you very much, Dr. Bulavinova. Dear Katerina, it's a pleasure to start that second series of webinars for our dear colleagues in Ukraine. And today it's my utmost pleasure to introduce to you Professor Stefan Elias. He has been one of my predecessors in ESCAP presidency. Before he had been the treasurer of ESCAP. He worked with the board of ESCAP for many, many years, and he is still a very important counselor for our scientific congresses. Stefan completed his medical studies and began his clinical training in child psychiatry in Geneva. To further his expertise in neuroscience, he trained at Stanford University in California, specializing in the use of advanced brain imaging techniques to better understand the relationship between brain structure, cognitive functioning, and the developmental disorders. His research focuses on learning difficulties and psychological disorders in children, particularly those with 22q11 deletion syndrome, autism, and other neurodevelopmental conditions. Upon returning to Switzerland, he led the public service of child and adolescent psychiatry and special education, l'Office médico-pédagogique in Geneva for 15 years. And since 2013, he has been directing the foundation Pôle Autisme, which he founded together with families and donors to promote care, research, and training in the field of autism spectrum disorders and associated developmental disorders. And I had the pleasure to visit him there and to meet his team. And it's really a very special place in the middle of Geneva, next to the Opera House, to have a big building with plenty of therapists doing work with these families. That's very, very impressive. So it's not in a clinic far away from the center of the city. It's really in the middle of the city, and that's a very impressive form of supporting children with developmental disorders. So today, Stefan's talk will be, could you mute your microphone? We have some of you, Stefan will be talk about the psychopharmacology of ADHD. Stefan, the floor is yours. I'm happy to have you here.
Дякую, професор Фегерт. І хочу сказати всім, що у вас буде можливість задавати питання. Ви їх можете писати, як зазвичай, в чатик, в коментарі. І потім ми будемо наприкінці їх зачитувати і отримувати відповіді. І професор Йорг Фегерт з нами лишається до кінця, тому ми можемо отримувати відповіді одночасно від Стефана Ельє, а також професора Йорга Фегерта. Тому прошу команду вивести професора Стефана і презентацію на екран. Дякую. Продовжуємо.
Thank you so much for the introduction, Jörg. And so I hope you see my slides, right?
Yes.
Okay, that's perfect. And so today, so as Jörg told you, I'm here in Geneva. This is almost like, I don't have such a view from my office, right? But this is roughly the place where I am, in the center of the city, because we wanted families from all the states to have an easy access to our clinic. And but when I'm not at the clinic, I like to spend time in the mountains, and those are views that I just wanted to start my presentation with. Le Grand Combin in the summer, Les Alpes in the fall, and here this is what I do in the winter with country ski. Okay, so today I'm gonna try to do a very practical presentation for you, telling you first about the basic consideration for optimization of the pharmacological treatment of ADHD, understanding the action of stimulants, and at the end talk about titration strategy and optimization. So on purpose, you'll see that I have quite some slides, so that if you want to read this material or go back to the material after the talk, you will be able to do it. Okay, so a few basic consideration for optimizing the pharmacological treatment of ADHD. So first of all, I would advise you to don't do complicated dosage, okay? That's the first thing, and I'm going to come back to that. Avoid using medication on the basis of habits. Rely on new publication, because today you really have a lot of different options. And those options also means that you have the tool to specifically respond to the request of a patient. You know, for some patients, they might be willing to be covered during school hours. For others, it's important to be also covered in the evening when they do sports. And today you have different forms of medication that allow you to do that, and we're going to come back to that. Respect the guidelines, right? I think the guidelines are really well done. And if you deviate from the guidelines, you should know why you do it. And especially in the order of the medication, they have sense, and they are really have been built according to science research. So there are several guidelines, and the Quadra, the NICE, the German guidelines. I really like this paper, which is I think a very good summary paper. And I extracted from this paper the comparisons of the different guidelines. And I think that it's interesting to look at the different guidelines and compare them in order to be able to really see what the difference are, because this you will learn from this. And so if you look at the different parts of the guidelines that I have put in the slides, it extracts a few general principles. The first one is that in general, you are probably not going to start pharmacological treatment before the age 5 or 6. Sometimes you might have to do it, but then I would advise you to do it if you're someone who is really trained into that and you're used to prescribe stimulants to young kids. The second consideration is that the first line of treatment is psychoeducation and psychological treatment, especially if there are comorbidities. Medication should be preceded or at least combined with psychoeducation, okay? Because if you don't, you will see that you will have much less adherence to the treatment and much more dropout. People have to understand why they take a medication and what their disorder is about. You will also see that in the guidelines, there are some differentiation between kids that are depending the guidelines, right? Between kids who are between 6 and 11 and older teenagers. Some guidelines do a differentiation between the psychostimulants. For example, some guidelines say, okay, any type of stimulants, you can start with any type of stimulants. And some other guidelines, like the NICE guidelines or the Swiss guidelines, they say, you know, start with methylphenidate long-acting forms, and then only you can go to dexamphetamine or lisdexamphetamine. And some, like the Canadians say, start with what makes the most sense according to the clinic of the patient. Do not use open label medication like neuroleptic medication or things like that for the treatment of ADHD if you didn't go through the first step. Okay. By the way, I don't think we should prescribe neuroleptic medication for ADHD. We can talk about this in the question session. Don't forget the comorbidities, okay? If there are comorbidities, you also need to address the comorbidities. And in ADHD, you very often have comorbidities, right? So don't forget that. Your aim should be to achieve a treatment that will make the symptoms completely disappear. Okay, this would be your aim. So the treatment should be fully effective with a minimum of side effects. So you have to balance those two aspects. And you want to treat the whole day or most of the day. Okay, so that would mean a fully effective, well-tolerated, and full day coverage. The treatment should be simple, ideally 1 pill a day. If you start multiplying the pills during the day with patients and families with ADHD, you will start having problems. They will forget the pills, and the adherence, the compliance to the treatment will go down. If it's too complicated, you will lose patients. A few words about psychoeducation. And I put you a few references here. So psychoeducation is really a valuable approach for the child or teenager, but also for the parents, okay? Psychoeducation and non-pharmacological approach are not a substitute. They're really a complement. The two go together. I'm going to come back, to this in a second. Somehow I lost the screen. Okay. Why? Because psychoeducation will improve ADHD symptoms. So there are very many publications showing that. It has a benefit for school in school behavior. People who do psychoeducation have better adaptation in the school setting. It has an impact on family dynamic. It can reduce, psychoeducation can reduce ADHD-related family stress and improve the social interaction at home. And there is a greater adherence to treatment if people do understand what ADHD is through psychoeducation. And there's a better adherence of the child, but also from the parents who support the child into the treatment. So the mechanisms of psychostimulants, so you have to keep in mind that they will basically have an action on the dopaminergic and norepinephrine system, who are both neuromodulators. So dopamine and norepinephrine, they modulate the excitatory system that is the glutamatergic system. And so if you start with methylphenidate, methylphenidate does only one thing. It inhibits the dopamine or the norepinephrine transporter. So it will do that the dopamine or norepinephrine stays longer in the synaptic cleft, and therefore there is more signal, okay, between the system. The dexamphetamine has a more complex action, much more complex, in fact, because it does the same as methylphenidate, but on top of it, it also reverses the uptake system, and it allows more dopamine to come out, and it blocks the stockage in the vesicule, and so there is then more dopamine or norepinephrine in the system that can come out. Okay, so at least a triple impact. So that's the simple version, because if you want to know more, and that's a reference, in fact, it also has an impact, the dexamphetamine, on other systems. It also modulates the serotonin reuptake. It inhibits the MAO system. So you see, dexamphetamine has a much more complex mechanism than methylphenidate. And therefore, I can see the point in some guidelines about starting with a medication that acts only on one system before moving on to a medication that has a more complex range of effects. So a few words about methylphenidate. It was created by a Swiss-Italian person, Leandro Panizzon, in 1944, which means that we have 80 years of observation. So we really know a lot about the effect of this medication. And what he did is that he decided to give it to his wife, who was named Rita, and she observed that she was playing tennis better when she was taking this medication. And so then he thought that it was good first for the treatment of depression and asthma. So this is how it was introduced. And then finally, it was also really prescribed from the 80s on to what we call today ADHD, that at the time was called minimal brain dysfunction, okay? So we really have a huge insight about this medication. There are two forms of the medication, two enantiomers, a left and a right, and it's mainly the right that is active. One thing that you have to know is that usually we say, okay, if you take a long-lasting form like Concerta, the goal you will have as a dosage, it's approximately 1 milligram per kilo per day. But you have to consider that there's a huge variability in the absorption and the metabolism. On the bottom figure on the right, what you can see is that if all those patients got the same dosage in terms of weight, their absorption is very different. And in some patients, the final concentration is the blood for the same dose is 5 nanogram per milliliter. And then for other patients, it's 35. So you can go from a range of, because of the difference of absorption and metabolism, you can go from 1 to 7. So when you prescribe, in fact, you never know really how much the patient will absorb and how much will be in its blood. So you'll see this is really something you have to keep in mind. If you give a shorter form like Medikinet MR, Equazim, Ritalin LA, you will usually shoot a target of 0.7 to 0.8 milligram per day, but you will have to adjust according to the absorption on the patient in order to be sure that your patient is well treated. So a rigid prescription will not work. You will have to adapt to the patient. So then you increase the medication by steps of an increase every 2 to 4 weeks. Do not go too fast, because if you go too fast, your patient will have more secondary effect and he will drop out. But don't go too slow, because if you go too slow, the patient will think, okay, this doesn't work. I am not going to do the trial. So you have to find the right balance. You have to explain to your patient that at the beginning, he might not feel an effect and that this will build up, and that you have to go slow so that he doesn't have too many side effects. Okay, I will come back to the side effects. Okay, so we say that there is really an effect of absorption, but there's also an effect on diet on the absorption, okay? Which is not the case with dexamphetamine and lisdexamphetamine. It's only for methylphenidate. So a brief pharma repeat, okay? So when you take a medication, there is a shoot, it goes to the max peak in the blood, and then it goes down. But the effect will only start when you have the minimal effective concentration in the blood, okay? You don't have an effect from the very beginning on. You need to have a minimal concentration in your body to have a benefit. Okay, and now if you look at that, if you look at a patient that was fasting in black and a patient that was eating before taking the medication, you see that the absorption is like, let's say, total absorption maybe 20% different. But if the effect is only above the red line, which is the minimal blood concentration to have an effect, you can see that in this patient, the difference was huge, because what the patient will feel is what is above the line. So you see how having eaten before or not can have a huge effect on the final effect because of this, okay? And so those are different figures. So this is Ritalin slow release here and the effect, and you can see it's almost, for this patient, it will look like it's almost the double of the effect. And for immediate release here, it can be a smaller difference. Okay, so there are three benefits, at least, to take the medication after the breakfast. It's that the first one, it's easier to remember. The second, you have less discomfort, less secondary digestive effect if you do that, but you will also increase the absorption and reduce the anorectic effect. There is also, so the benefits of methylphenidate is that it's very quickly effective. You can do intermittent treatment if you want to have only effect on short periods. There are some effect to consider. There's often a rebound at the end of the day because the half-life of methylphenidate is short. And so when the medication is not effective anymore, approximately 1/3 of the patient will have a rebound, meaning they will feel tired, sometimes irritable, and they are more active again, even more active than the days where they don't take the medication. So if you don't say to the parents and the family that sometimes there is a rebound effect, then the parents who haven't seen the child during the day when the medication was effective, but they don't only see it in the afternoon when they come back from school, might tell you, but this medication doesn't work. It's worse. No, it's not worse. It's worse when you see your child because he has a rebound effect. Okay, so keep that in mind. If there is a rebound effect, you can give a longer form, or when there is a rebound, you can give an additional small dose of immediate release methylphenidate to compensate the rebound. Okay, so you would give, if you took Medikinet MR that lasts for 8 hours, you would give another maybe 5 or 10 milligram of methylphenidate immediate release when he comes back from school, if he has a rebound effect. Okay, other side effects are really hard. The most common are digestive side effect, and then you have others like headaches or sometimes tachycardia, and you could have an impact on growth. I will tell you more about this. Okay, so the advantage of long-acting form is that you don't have to take the medication several times, and you don't have the peaks and bumps. Okay, so you definitely want to give a long-term medication. There are different forms of long-terms. Typically Concerta, which is here, you have 25% immediate release, and then the rest goes during the day. As some Medikinet, for example, it's a 50-50, half in the morning, half in the afternoon. And then you have different forms depending on when you want the medication to be really effective for the child or the focus of the medication. Okay, so just that you know, so this is a pill of Concerta, so that you understand the way by which this is a long-term medication. So The outside, a quarter of the medication is on the outside, 25%. And then the rest is an osmotic release. That means that when the pill comes out of the stomach and goes in the intestine, then there is an osmotic effect and it will push out the methylphenidate like a little syringe that you would have swallowed, and it will go out during the time it's in the intestine, and when it goes out to the colon, the effect will stop. So if you have a fast intestine, it will last less. If you have a slower pace of intestine motility, it will go out faster and last less. Okay, so there's also a mechanical aspect that will impact the total duration of the medication. Medikinet, for example, is another principle. There are 50% is immediate release, and then there's coated slow release, and this will then dilute at a pH of 5.5. So when it comes to the stomach, so the first 3-4 hours are covered by the immediate release in the stomach, and then it will take over for the slow release in the intestine. Dexamphetamine, or lisdexamphetamine. So lisdexamphetamine is a very smart pro-drug. It means it's not effective, it becomes effective in the blood. So lisdexamphetamine, or Vivance or Elvance, has a lysine on a dexamphetamine group. When it ends, so this is absorbed very quickly. So the medication is super well absorbed, doesn't depend on food, or very, very not much. It peaks in the blood, and then it's cut by an enzyme that is in the red cells. And it will then be cut in the lysine and in the dexamphetamine, which is then the active form of the drug. Okay, so if you look in the blood, you have a peak of dexamphetamine, and then you have a long lasting curve that will cut the over time, and you can see that the half-life, in fact, is quite long. It's approximately 10 hours. So this means that at the end of the day, you still have dexamphetamine in your blood, and the next morning you still have dexamphetamine. Okay, so the advantage of that is that because it goes down slow, you don't have a rebound effect. The disadvantage is you might have more sleeping problem because the medication lasts longer. Okay, so, and as I told you, it's not dependent on meat, and the peak is not dependent. The peak is approximately 4 to 5 hours. So you can also take pure dexamphetamine. In Switzerland, it's only for kids. It's not for adults. And the tabs are relatively small dosage. So it's really more meant for children if you want shorter period of action. If you do it with teenagers or adults, you're going to get lisdexamphetamine. The good thing about stimulant is that they're very effective. Okay, we have very few medication in psychiatry that are as effective, because at least 70% of patients will respond to methylphenidate, at least 70% to dexamphetamine. If you combine the two, you have a response in more than 90%. Okay, so almost everybody will respond to stimulant if they are correctly prescribed. So which one is more effective? So people have looked at that. If you give, medication to 100 people, that was 174, and then they gave it to the first medication and the second medication, and they looked how did they respond to those two medications. So 40% will respond the same to methylphenidate or dexamphetamine. 28% will respond more to dexamphetamine than methylphenidate, and 15% will respond more to methylphenidate than dexamphetamine. So globally, you could say that maybe dexamphetamine is a bit more effective, which is true, by the way, than methylphenidate, and only approximately 10% will not respond to either or. So what do you do if the patient do not respond? Okay, so I give Concerta or Medikinet and the patient doesn't respond, which will happen to roughly 20 to 30%. Okay, so the first thing you have to be sure is that the patient really took the medication. The patient is compliant. Then the second question you have, okay, you're sure he takes the medication, the dose you prescribed, the parents are checking. And so you have to watch if the drug is correctly absorbed, because he might be one of those patients that is a poor absorber of methylphenidate. Another cause could be that there's a problem with comorbidities. So there's a response, but because of the comorbidities, he doesn't respond as well. I give you an example. If your patient has a sleep problem or an addiction to cell phone, and he spends, every night until 1 or 2 in the morning on his cell, and he sleeps 4 or 5 hours a day, for sure, you're not going to be able to correct that with a psychostimulant. A patient needs to sleep enough to be able to be concentrated the next day. Okay, so you have to check that, especially the cell phone problem, which is quite common, right, in teenagers with ADHD. Another possibility is if he has a lot of comorbid anxiety. Maybe he doesn't respond because part of the problem, part of the clinic is due to an anxiety problem that you need to address also. Okay, so use a systematic approach to really understand your patient and optimize the care. Okay, so in children, the difficulty might be also that he doesn't take the medication, as we said. In teenagers, sometimes they forget, or sometimes they reject the medication. If one parent believes that he should take the medication, the other one doesn't want that his child take the medication, this can often put the child in a position of loyalty conflict, and he will, without telling you or without telling the mother, he will not take the medication. So in adults, there's sometimes a lack of structure, and they don't take the medication. They don't understand that you say that he should take the medication at this dosage, and he took it at another dosage. Okay. So to improve adherence, you can use, pillbox, reminders, smartphone. You can try to make a ritual to always take the medication at the same time. And you have to be sure that the patient doesn't reject the medication. Questioning, rejecting the medication in teenagers with ADHD is the rule. Okay, most of them at some point will question the medication. I think it's a normal process, and we'll talk about this. Okay, check the drug absorption. Be aware that in children that do have gastrointestinal problems, like children with autism or other developmental disorder, there is more common absorption problem. Okay, so these kids often need higher dosage because of an absorption problem, not because they don't respond to the medication, but they don't absorb as well. Okay, that's at least one cause. I'm sure of that because I often do a blood dosage that you might not be able to do depending where you are, because it requires some sort of a special lab to do the dosage of methylphenidate. But if you check systematically, you will see that they don't absorb as well. If they take other medication like SSRI or antacid at the same time, they might not absorb as well. Okay, so what you can do if you have this lab available is that you can dose the methylphenidate in the blood, and you should be at a target dosage of 15 to 25 nanogram per milliliter. I'll come back to that. If it doesn't work, methylphenidate doesn't work, then switch to lisdexamfetamine. You don't have to wash out. You stop one day and you start lisdexamfetamine or dexamfetamine the next day. Okay, you don't have to wait. Lisdexamfetamine is not dependent of gastric pH. And so when you start again with lisdex, after having stopped methylphenidate, you should start again on a lower dose and increase progressively. Okay, because if the patient was not absorbing methylphenidate well, and you may move to lisdex that he absorbs very well, he might have a lot of secondary effect if you started at a dosage that is too high. Okay, and then he will be discouraged and he will stop the medication. Okay, when both don't work, neither methylphenidate or lisdexamfetamine, which is very rare, less than 1 in 10, then you move to non-stimulant. But most of the time, you move to non-stimulant if you have a lot of secondary effect. A typical secondary effect is digestive problem. I had a teenage patient that was responding very well to methylphenidate and dexamfetamine, but each time she had very painful nausea and belly cramps, and so after a while she was always giving up. So I had to switch her to non-stimulant medication. Another common side effect can be a big loss of appetite if the child is very thin, and this can be really a problem, okay? Another problem can be tics. Some kids, especially those who already have tics, can have an increase in tics. Most of the time, the increase in tics is transitory. It will then, after 2 or 3 weeks, it will decrease again. But if the parents are very worried, or if they don't decrease, you might have to reduce the psychostimulant, and you can then either switch to a non-stimulant or combine with a non-stimulant. Okay. Most of the time I combine them. Okay. When I have a problem with secondary effect. So what should you know about non-stimulant? So non-stimulant are mainly atomoxetine and guanfacine. So atomoxetine has a side effect of an effect size of approximately 0.32. Guanfacine has a higher effect size of approximately 0.708. To give you an idea, methylphenidate is around 0.95, and lisdexamfetamine is around 1.2. Okay, so it gives you the effect size of those different medications compared to each other. Okay, so how does guanfacine function? So guanfacine is basically blocking a postsynaptic channel so that the signal does not escape and it maximizes the signal. So this is how guanfacine functions. Okay, atomoxetine is a norepinephrine reuptake blocker that will act slowly. So it blocks the reuptake, and it only works after at least 7-8 weeks before you have an action. Unlike stimulants who work immediately. Okay, so the patient has to be aware of that, because if he took stimulants before, he might expect a very quick effect, which will not happen with atomoxetine. I put you a more technical slide for those who are interested to understand the effect of guanfacine underneath. This effect is still studied, okay? And it might have a favorable long-term effect also, at least on animal models. If you give equivalent dosage per kilo, you will have more of an effect in children than in adults, okay, with a higher concentration. So you start slow and you go slowly, okay? The half-life is 18 hours. It's a non-stimulant, and the main side effect is sedation. You get sleepy. So this is why you usually give guanfacine in the evening, okay? So that the sleepiness and the peak of side effects occurs during the night when the patient sleeps, okay? 18 hours half-life means you will acquire the steady state after 4 days, okay? So I told you the main side effect is somnolence. Another common side effect is hypotension. So when you introduce guanfacine, I would really advise you to introduce it slowly. The recommendation in the notice of the medication is 1 milligram per week. You increase 1 milligram per week. In my experience, this is way too fast. If you go so fast, you will have a lot of dropout because the patient after 1 week starts coming out of sleepiness, and then you already increase the next dosage. So I would advise you to wait 3 to 4 weeks between each increase. The target dose, and so you cannot chew the medication. So for example, if you give this medication to children with autism that chew the medication, in fact, you lose the retardation effect. So you can't use it in that case, okay? And there's some interaction with grapefruit juice on the metabolism and things like that. So the recommendation dose is between 0.05 and 0.1 milligram per kilo per day. Okay, so roughly if the child is 30 kilo, you will have a target of approximately 2 to 3 milligram per day. But you will do 1 milligram per day for 2 to 3 weeks, then you will move to 2 milligram per day for 2 to 3 weeks, and then you will arrive to 3 milligram per day, okay? You cannot stop this medication at once, because if you do so, there is a hypertensive rebound. So when you stop the medication, you have to go down slow. You reduce 1 milligram per week. So if you were at 3, you take 1 week at 2, and then 1 at 1, and you stop, okay? Which means that you have to have a patient that is compliant, that will not stop the medication at once, okay? The other thing is you do not stop the medication during the weekends or during the holidays, okay? Because you go up slowly and you have to go down slowly. So if I have a two-week holiday, you won't stop the medication. If you combine the medication with a psychostimulant, you will not increase to the same dose. You will take a lower dose, typically for an old teenager that like 60, 70, 80 kilo, I will only go up to 5. So I would give only 2/3 of a dose that is non-combined if I combine it. So if you combine, you really do have a good effect. It increases the effect, okay? So there are few studies, but if you give just a psychostimulant in gray to the same patient, or if you combine the psychostimulant and guanfacine, especially if you give the medication in the afternoon, you tend to have the guanfacine in the afternoon or in the evening, you have a better effect. It's very favorable. I have found in my experience that it's especially favorable when the patient has tics, because it's a quite effective medication on tics. I also prescribe guanfacine in Tourette syndrome with very good effect. There's a beginning of a literature about that. And as you know, ADHD is a comorbidity of Tourette syndrome. So it's not unusual to have a patient with Tourette with ADHD. And so giving guanfacine is then an interesting option. I'm not going to be too long on atomoxetine, but you have to know that there's the first thing is that it's not acting immediately. As I told you, you have to wait 6 to 10 weeks to have the full effect, okay? And there is a variability in the metabolizing rate. There is a subgroup of patients who are very efficient to metabolize atomoxetine, meaning they will have a very low dose of atomoxetine compared to those who have a slower rate of metabolization of atomoxetine. So you can have quite a variability, and you will not know if your patient is a fast or a slow metabolizer. But if a patient do not respond to atomoxetine, he could be a very good metabolizer, and you will have to give a higher dosage. Okay. So this is a summary slide that you can look afterwards just to compare the different medication for the essential. So in the last part of my presentation, I'd like to tell you a few words about titration optimization. Okay. So one thing that is probably the most important, before you start, it's really important that your patient has the feeling that you understand him, because he will have to take this medication a long time. So if you go too fast, if you don't listen to your patient, if he doesn't have the sense that he is understood by you, he will most likely stop the medication. Okay, because there's a lot of fake news about psychostimulant and medications for ADHD. And so he has a high risk to interrupt the medication if he's not sure of what you say, if he doesn't trust you. So the relationship is very important when you medicate those patients. It's not just about giving a pill, right? The discontinuation is the rule, okay? After 1 year, there is less than 23% of the patient who are still taking the medication with good adherence. So you might think that you're a very good GP or pediatrician or a child psychiatrist, but most likely your patient will have to experience some stops. And so I think you have to be with your patients in those experiences. It's okay to stop. And I usually, if a patient tells you, I want to stop, okay, we stop. And we check, we see if it's how it goes. And if you stay with your patient through that experience, and so that if he wants to start again, we are with him and you will start again. And sometimes patients want to change medication. They want to change dosage. I stay with them through these steps in order not to lose them. Several factors can improve the adherence. Like younger patients, they are more adherent because the parents just give the medication. A long-acting formulation is better than short-acting. There's more adherence. The presence of comorbidity. If a patient has comorbidity, he will be more adherent. Some patient will also influence, like the attitude, the knowledge about ADHD medication, and as I told you, the relationship that you have with your patient. So a few things about dose optimization. So start low and go slow, but not too slow, as I said, okay? Because he has to feel that the medication is helping him. Increase the dose until there's no ADHD problem anymore, or that there are side effects that start to balance the benefit. The optimal dose is defined as the dose above which one there is no more improvement. Okay, so typically this for methylphenidates, it's like 30 to 22 nanogram by milliliter. If it's dexmethylphenidate, it's half of it. Okay. People have looked at the plasmatic dosage and the correlation between the occupancy of the so the blockage of the dopamine reuptake canal. And what they have seen is that when you start medicating with the normal occupancy of the neurotransmitter with the dopamine who is already there is approximately 40%. As you basically block the channel, the occupancy increases, but you see that you will never go beyond 70 to 80% of occupancy of the dopamine transporter, the saturation of the dopamine transporter. So basically what it tells you is that you have a sigmoid dose response curve, and that you want to be just beyond the saturation, okay? So how can you look at this? You can look at this. So here there is a group of patients that got medication. And what you can say that probably people under 5 nanogram per milliliter, they will really have absolutely no effect of the medication. And then here they will probably start to have an effect, and that beyond 22 nanogram per milliliter, 25, you can give 2 kilo of methylphenidate, it will not change anything. Okay, so you want to be in that range. And what you also see is that patient here who got a very different dosage of methylphenidate, they have a very wide distribution, right? Here a patient who got 1 milligram per kilo was in the very low range, and here it was above the range. Okay, here was a patient with 1.2 milligram per kilo, and he didn't go even under the lower part of the range. So you remember the variety in absorption. So this is where you need to increase the dosage, okay? And this is the zone where even if you still increase, it won't change anything. Okay. Keep in mind, as I told you, that there is a significant proportion of the patient with 1 milligram per kilo per day who will not be in the therapeutical range. So you might have at least 1/3 of the patient with Concerta, you might have to go beyond 1 milligram per kilo per day. Okay, a few words about the side effects, okay? The fear of side effect is the #1 cause why patients do not engage in treatment. So it's very important for you to know those side effects so that you're well informed so that you can inform your patients. So here are a few. First question, does it have an impact on growth? The response is yes. If you take a psychostimulant for a few years, your size will be 2.5 centimeter lower than if you wouldn't have taken this medication as an adult, okay? So if your parents are, 190, 2.5 centimeters might not be a lot, right? If this is your target size. But if you should be 170 for a boy, maybe every centimeter is important for you. Okay, so you have to keep that in mind. There has also been a literature showing that rhythm problems and sudden death could be more common in people taking psychostimulants. So there is a recommendation that you have to look for a family history of sudden death or heart rhythm problems in young people. Okay, if it's the grandfather who was 85 and had a rhythm problem, that's normal aging. But if there are rhythm problem in young people in the family, you should definitely do an electrocardiogram when you prescribe, before and after prescribing. Blood pressure will also be slightly increased. Okay, so you have to do regular blood pressure measurement before the introduction and after. Electrocardiogram is not systematically recommended, only if there's heart malformation and a history of heart rhythm problem in the family. So this is a very recent meta-analysis that shows a very good one by Samuel Cortese and Farhat, and it was presented at the ESCAP Congress, by the way, this summer in Strasbourg. And what you can see is that overall, there is a small effect of amphetamine, atomoxetine, lisdex, methylphenidate on pulse rate, 2-3 beats per minute, blood pressure, but you have to check it. Sometimes you will induce hypertension. In my experience, it was always with teenagers that were overweight. I never had that problem with children. I only had it with teenagers, and usually they had other risk factors, but you want to check. Guanfacine will reduce blood pressure, and as I told you, this will correct over time, but you have to introduce slowly. What's the risk of psychosis? There is an increased risk of psychosis, but if you look correctly, and that was a very good paper in New England, the risk of increasing psychosis seems to be especially for amphetamine. Methylphenidate, so dexamphetamine, methylphenidate does not seem to increase the risk of psychosis, or very moderately. Dexamphetamine is yet can be a stronger effect. So if a patient has a family history of psychosis, he has a father or mother with schizophrenia, or he has a genetic disorder like 22q11 deletion syndrome that puts him at higher risk to develop psychosis, I would definitely not give amphetamine. I would stay to methylphenidate because you accumulate the risk factors, right? What about people with bipolar disorder? So individuals with bipolar disorder are at higher risk of conversion if you treat them with psychostimulants. But if you treat bipolar disorder first, you will limit or not have a difference. So if there's a patient with bipolar disorder with ADHD, you should absolutely first treat bipolar disorder with a mood regulator and then treat ADHD. That's the right order. However, sometimes it's very difficult to see a bipolar disorder in a child or a teenager. So you have to look for a history of bipolar because there is a greater association, okay? This is a very good paper that shows the greater association between bipolar and ADHD. So when there is a history of bipolar in a parent, grandparent, be sure to check for potential bipolar symptoms in the child or teenager. If you do have signs, you know, like accelerated ideas, hypersexuality, increased consumption, then you have to be careful, and you would definitely first treat the bipolar disorder in that patient. Okay. Stimulant medication and substance abuse. In fact, because most of the time parents are worried that use of stimulant could increase the future risk of addiction. And what the literature shows is that it's the opposite. In fact, patients with ADHD who are treated with stimulants have a lower risk of addiction, okay? And there are several papers, so that's a very good reference. And that's another one that I thought very interesting that shows that if you want to mitigate the risk of addiction in ADHD patient, it will be more efficient if you start earlier in childhood and if you treat longer. Okay, in other words, probably that you're more protected from addiction if you have ADHD and you're treated, but you're more protected if you start medication as a child, which makes sense because if you start medication as a teenager and you already met the consumption, you already started smoking weed, or you already started alcohol or nicotine or gambling, it's going to be much harder to have an impact on the addiction just with the medication of treatment of ADHD. Okay, you already have an addiction then, and it's not a treatment for addiction. Okay, it's not. Overall, treatment of patient with ADHD will reduce the rate of psychiatric hospitalization. It will reduce the risk of suicide attempt, probably because you decrease the impulsivity. And in general, it will reduce the rate of non-psychiatric hospitalization also. Less accident, better health. People have looked at comorbidities also, and it seems and some of the natural course. And what is interesting is that comorbidities like obsessive compulsive disorder or anxiety or substance use are linked to a higher rate of treatment interruption. No surprise, right? More changes of medication, switching of medication. So it's really important to also investigate comorbidities before you start the medication, because if a patient has a comorbidity, you also have to treat the comorbidity. Colleagues, pediatricians, or so on, they often ask, what should I treat first, the comorbidity or ADHD? Well, start with what is the most problem to the patient. If the patient tells you my main problem is ADHD, and this is why I'm so anxious because I'm worried about failing school, start with ADHD. If the patient tells you, you know, my big problem is really my anxiety disorder, start with treating the anxiety disorder, and then you'll move to ADHD. So I see Jörg showing up. This probably means that my time is coming to the end. I have a few slides that you will find at the end of my presentation, and I'm very happy to respond to your questions.
Thank you very much, Stefan. So if you want to finish with some slides, I think we are fine with time. I just reappeared to show you that the hour is over, but
Okay.
Take your time. I think it was an excellent lecture.
So I tell you a few things about what's new. Okay, what are the trends? So there are a few trends, and I think they're interesting. There are more on the non-stimulant. There are two trends. One is on the non-stimulant end, and so there's the medication called cintanafadine that is in fact a reuptake inhibitor for serotonin, norepinephrine, and dopamine. That seems to have quite some good effect. It's also a long-acting medication, so that could be really something coming. And for now, it's tested on adults, but it's certainly going to be also effective. And if you look at the effect, it's very comparable to methylphenidate. Same with another molecule, viloxazine. So those are new trends, and I think that's good, with less secondary effect, but a bit less effective than lisdexamfetamine. Another medication that you have heard about is viloxazine. So this is again a selective norepinephrine reuptake inhibitor that was used before as an antidepressant, and that has an efficacy that is comparable to atomoxetine or methylphenidate. And what I would what I would suggest to you, if you have an interest in those medication, is to listen to the YouTube channel of Dr. John Cruz. This is a professor at Stanford. He's a bit of a geek, but he's very knowledgeable, and I think he has beautiful YouTube videos. Not very charismatic person, but very knowledgeable and very educated. Last trend, and then I will stop there, is another prodrug that is called ser-dexmethylphenidate. So it's a serine group that is on a dexmethylphenidate. The advantage, so it's also a prodrug. It's a bit like the least dexamphetamine, but here it's a dexmethylphenidate. So it's very well absorbed. Because it's a prodrug that is transferred inside when it's absorbed, it has a long effect of 10 to 13 hours. It's a capsule that can be open. And so this means that you can chew it. If you chew the capsule, it will not destroy the long-acting effect of the medication. Okay, so I think I will stop here, and I think I told you most of what I wanted. And I'm ready for the questions.
Thank you very much, Stefan. I hand over to Dr. Bulavinova, because I'm sure that Katerina has quite a lot of questions already. Thank you very much.
Дякую, Йорг. І так, є багато питань, тому задаю по одному. Буду намагатись не дуже швидко говорити, щоб було зручніше перекладачам. Олександра Матвіюк питає: в Україні дорослим з РДУГ часто діагностують біполярний розлад і кажуть, що РДУГ – це модна хвороба, і у дорослих її немає. Як ви ставитеся до такої думки, і чи діагностуєте ви у дорослих РДУГ? Які є гендерні особливості РДУГ у дорослих жінок і чоловіків?
Okay, so that's a very good question. First of all, I think there are quite some difference, right, between bipolar and ADHD. Acceleration of thoughts in bipolar patient or hypomanic or manic patients that you won't have in ADHD. They might be hyperactive, but there's no acceleration of thoughts. Normally, they shouldn't be hypersexuality. They don't tend to spend so much money and so on. They may be impulsive, but impulsivity is not an acceleration that you will find in manic or hypomanic patient. And then there is no depressive phase associated with attention problem. Okay, so that's already one thing that should help you differentiate. So yes, I think ADHD is common in adults. There are probably different subtypes of ADHD. First of all, a lot of adults with ADHD are children and adolescents with ADHD that didn't have a complete disappearance of symptoms. In general, children and teenagers with ADHD tend to lose hyperactivity and impulsivity. Probably 2/3 of them have a very substantial decrease of impulsivity of hyperactivity. This is less true for attention problem. So fatigue, attentional deficit, distractibility tend to persist in at least 70% of the children and teenagers with ADHD. Symptoms tend to improve, including in the 20s, but still a lot of adults will have residual symptoms of inattention. So this is a first group, and I think we have not been as good in the past to identify attention problem. So when you see parents of children with ADHD, they often tell you, but now that you describe that and I see my child, I think I had the same. And I struggled in school and I was never treated. Sometimes they regret that they couldn't not have treatment at that time. So I think it is not a fashion, okay? There are really adults that do have attention problem, or were children and teenagers with ADHD. In a publication by Moffitt's maybe 5-6 years ago, she also showed, which is more surprising, that there's a subgroup of a teenager that will start having ADHD only during adolescence. So it's difficult to say if for those teenagers or young adult, ADHD started really at that time, or if they were individuals who fluctuated in their attention problems. There has been a few studies that have longitudinally followed children and teenagers with ADHD. And what you see is that the symptoms are not constant. In 2/3 of the children and teenagers, symptoms are fluctuating, and in 1/3 only, the symptoms are quite steady. So again, you can have a child with 10 years that has a lot of symptoms, then at 12 or 13, he will do better, and at 17, he has again more symptoms. Okay, so keep it in mind that this is a fluctuating syndrome or disorder. And I'm not going to go too much into details, but we have some reasons why this could be.
Угу. Так, зараз ще задаю питання. Хвильку. Софія Коваленко питає, якщо пацієнт не прийняв гуанфацин 1-2 дні, то потрібно починати приймати препарат спочатку 1 мг, 2 мг, чи продовжується приймання препаратів з тої дози, на якій зупинились?
For what medication are you talking here?
Guanfacin.
For guanfacin, okay. No, so, okay, you don't want the patient to stop if he's at, 5, 6, from one day to the next, because then he will have a hypertensive rebound, right? His blood pressure will increase, and you don't want that to happen to your patient. So you really have to tell him that normally, if you start guanfacine, you really have to monitor that you take the medication. And so the packaging is made for that, right? But I think it will, if it's a patient with ADHD, you might have to tell to the parents that they have to be careful with that. If you miss it one day with a half-life of 18 hours, it's not going to be a problem. But if you start suddenly stopping for 4, 5, or 6 days, this is a problem, right? And if you discover after 3 or 4 days that he didn't take the medication, you should re-put it at the same dosage. But this is something you should monitor, and that should not happen. If you see that this teenager or this family is not reliable, maybe guanfacine is not the right option, and you should try atomoxetine.
Пані Наталія Церп'як питає, коли зрозуміти, що лікування варто припиняти?
I'm not sure I really understand. Could you just repeat the question?
Коли зрозуміти, що лікування варто припиняти?
Okay, so you mean the treatment of psychostimulant or a psychostimulant? When it's time to stop the treatment. Okay, so what I usually do is that I always suggest to take a break during the summer holidays, okay? So that the patient can stop for 3, 4, 6 weeks during the holidays and see how he does, and if he thinks that he wants to continue the treatment. So you do a break period. Now, having said that, for a young patient or a teenager, it might not be so easy to assess the effect. So you really have to discuss that with the parents also, because the teenager might not see the difference, but the parents and everybody around him might see the difference. if you make a period of stop during the holidays, during the summer holidays, and that this period lasts more than 2 weeks approximately, do not start again with the same dosage, okay? Because there is an adaptation effect and a resensitivation to the medication. And so if you were, like, say, at 54 milligram of Concerta just before at the end of the school year, and at the end of August you start again at 54, he will have a lot of secondary effect. It will be very hard for him to sleep, or, you know. And so if you start again, start a week at 36 before moving to 54. So with stimulants, if you do a greater than 2 weeks period, be sure to start again at one lower dose than the one you stopped before the break. So I think this is one reason, one way to do it. So reassess the effectiveness when you do the holiday break with your patient. And the other time when you're going to stop the medication is that if the patient thinks that it's not necessary anymore. And you can make a break and see what the result. Psychostimulant, they have such a short life. If you stop the medication on Friday, you will know on Monday what it is to be without the medication, right? Because it's very short life. And so if you see that you're doing less well with the medication at school, concentration, homework, then you can start again. If the patient wants to make a longer stop for more weeks, I say, okay, let's make an experience. The patient needs to do the experience. He needs to be sure that it's still useful to take the medication. I usually suggest to the patient not to do the experience just before the exams or an important school period, but then I do the experience. And we say, okay, let's stop for 1 month and reassess the result of stopping the medication. What did your parent think? What did the school think? What are your school results? Did they the same? Did they go worse? So, and I reassess it with the teenager. I often use semi-quantitative scales, that is the Conners, because I think that if you ask me how concentrated I was a month or two ago, I don't know, I don't remember. So if I do a scale where I test, you know, before and after, it will help me be more reliable about the way I assess myself. And I might be more confident in my assessment of the effect of the medication.
Пані Анастасія Рокотова питає: мала досвід того, що дитина при призначенні 1 мг мала виражені болі в шлунку. Спробувала ввести препарат по 0,25 мг і мали позитивний ефект. Чи можна так титрувати, чи категорично ні?
But it was 1 milligram of what?
Пані Анастасія, напишіть, чи ви про гуанфацин, чи про інший препарат, і тоді ми до вас повернемося до цього питання. Тоді наступне поки питання. Пані Дар'я Кияненко питає, про що може свідчити парадоксальна реакція на метилфенідат і схожі препарати? Дитина на фоні прийому метилфенідату стає збудженою, розгальмованою, дуже дратівливою, порушується сон. Чому таке може бути?
Okay, so you have to be careful to differentiate, as I told you, what you think could be a paradoxical effect versus what is a rebound effect. Okay, if you take the medication for the day, like Concerta and so on, and you see your child at 5 or 6, when he has a rebound effect, you might feel that the child has a paradoxical effect because you didn't see him at 1 or 2 in the afternoon. So before coming to the opinion that this is a paradoxical effect, it would be important to see your child the entire day. So this is why often when I start the medication, I suggest to the parent to give it on the weekend so that they will see their child the entire day. Because then they will be able, then you will ask them, but you know, in the morning, was it okay? So if you see this irritability, this sort of problems, agitation in the afternoon, it's probably the rebound effect. So that's one thing, okay? So beware of the rebound effect, at least a third of the patient with methylphenidate. Now, of course, at the beginning of the introduction of the medication, and each time you will increase the dosage, especially with lisdexamfetamine, even more than methylphenidate, you will have a harder time to go to sleep. These difficulty to sleep are most of the time transitory, especially the first week, each time you increase the medication, and then they tend to taper off. But if really you have too much problem at the beginning of the introduction of methylphenidate, what you can do is give a small dose of melatonin, like half an hour before going to sleep, and you can give 1 or 2 milligrams, and this will help for this secondary effect that most of the time is transitory. Okay, so after 3, 4, 5 weeks, you will stop the melatonin, and normally it should be okay.
Пані Інна Шевцова питає. Хлопчику 3 роки поставили діагноз розлад спектру аутизму, рдух і епівогнище. А у 5 років сказали, що розладу спектру аутизму немає, а тільки рдух і епі. Скажіть, хіба може бути, що розлад спектру аутизму є, а потім ні?
Well, right. According to the research, autism. Okay, you can fulfill the criteria for autism, and if you fulfill them at one point in your life, you have the diagnosis. Then sometimes, which is not so common, especially in a complicated situation with comorbidities, how you describe, normally autism does not really disappear. Now, autism might be more evident at some periods, but it seems a bit strange. So maybe this child has also other problems like epilepsy, and some of the symptoms are not so obvious, or somebody made a diagnosis of autism even if he hadn't the criteria. So it's difficult for me to say. But as you know, right, of course, autism also appears within some complex situation, and the fact that you have epilepsy, you know, is really concerning, of course, and he should also be checked for a genetic diagnosis, because the possibility of an underlying genetic cause, complex genetic cause, is higher when you have epilepsy and multiple comorbidities. Especially if you also have physical problems, you know, that or dysmorphia, then the recommendation is to do a genetic test to be sure you're not missing a more obvious biological cause.
Останнє питання на сьогодні, воно англійською, тому увага перекладачі, я його буду зачитувати англійською. Може, навіть 2 рази зачитаю, 1 раз для професора Стефана Ільє, а потім, щоб перекладачі могли перекласти його. І так, пані Діана Сушко питає. Please explain if a teenager has ADHD and ODD, opposite defiant disorder, with severe emotional outbursts, impulsivity, suicidal thoughts, would it be better to use neuroleptic and only after it works well to use methylphenidate? And what is better in such case, methylphenidat or lisdexamfetamine? And I am reading it once again, just for the interpreters to be able to follow. Please explain if a teenager has ADHD and ODD, opposite defiant disorder, with severe emotional outbursts, impulsivity, suicidal thoughts, would it be better to use neuroleptic and only after it works well to use methylphenidat? And what is better in such case, methylphenidat or lisdexamfetamine?
Okay, so I would definitely not start with neuroleptic medication. I would not start with neuroleptic, and I tell you why. Because of course, you know, it will reduce the sort of more oppositional, conduct disorder part immediately. But then the risk is that you will leave neuroleptic medication long term, which increases a lot, it will create a lot of problems on the long term, weight gain, more risk for metabolism, more risk of developing diabetes as an adult, motor problems, right? That is dependent on the duration of neuroleptic medication as well as the dosage. So I would not start with neuroleptic for sure. I would first start with a psychostimulant. I'm not sure you could know in advance if methylphenidate at the right dosage would be more or less efficient than Lisdex. So I'd probably, in Switzerland, I would have, because this is the guidelines, the Swiss guidelines, and you get reimbursed by insurances only if you start with methylphenidate. So I would probably start with methylphenidate long-acting in Switzerland. If I'd be in Canada, and where you can start with whatever you want, and the child has a lot of behavioral issue in the evening, then I would start with lisdexamfetamine because it lasts longer, and I want him to be covered when the family is together, because this is when there is the oppositional defiant disorder. So I would first start with a psychostimulant at the right dosage, okay? And if at the end, because very often there is also a favorable impact of psychostimulant on the emotional regulation. Okay, when you medicate the child for attention problem and impulsivity, he tends to be also better regulated with the more aggressive or, you know, outbursts. So I would definitely start with that. If you go to the right dosage, you know, full dosage, 1 milligram per kilo per day, or even a bit more if you have residual symptoms and there's still some mood problems, I would first assess which one, you know, is there also some anxiety problem? If there is residual anxiety or depressive problems, I would then add an SSRI and wait at least 8 to 12 weeks to be sure I have the full effect of the SSRI. Because I combined a psychostimulant and an SSRI, I need to do electrocardiogram to be sure that that's a recommendation, and you should do it to be sure that you don't induce a rhythm problem. And then if you still have the outburst, I would be sure that I also considered that this child could have a mood regulation problem, and I would of course be sure that he doesn't have mood swings, because it could also be, of course, a problem of a mood regulation in the first place. So in this child that has oppositional defiant problem, a lot of attention problem, aggressivity, be sure not to miss a bipolar disorder. So explore all the dimension of the diagnostic symptoms of a bipolar, not to be misled and think that it's
Дякую. І декілька організаційних речей. Ми пробули в цьому ефірі вже 1 годину 30 хвилин. І ми дуже дякуємо пану Стефану Ільє за його час, який є безцінним, і професору Йоргу Фегерту за його також безцінний час. Я бачу деякі коментарі від глядачів, тому одразу декілька повідомлень. Так, у вас буде доступ к відео, він вже є на каналі доктора Булавінова. У вас буде доступ як до української версії, так і до англійської версії. Ми вам будемо також ці версії розсилати там, де ви отримували від нас повідомлення про цей ефір. Будь ласка, повідомляйте ваших колег про те, що в нас почався 2-й сезон і що вони можуть реєструватись і також доєднуватись до нашого 2-го сезону. Бачу ваші коментарі про те, що в Україні нема доступу до багатьох препаратів. Я думаю, що це питання буде важливо підняти з Міністерством охорони здоров'я України, що ми і зробимо після цього ефіру, базуючись на ваших коментарях. Нагадую вам, що я є медичною експерткою Юнісеф Україні. Ви можете завжди мені написати, наприклад, на Facebook в месенджер, якщо у вас є якісь питання, і ми їх будемо узгоджувати. Я хочу ще раз подякувати професору Стефану Ільє за те, що він в свій неробочий час погодився проводити для нас цей ефір. І професору Йоргу Фегерту взагалі за все дякую. І прошу професора Фегерта закривати сьогоднішній ефір.
Yes, thank you, Katarina. Thank you, Stefan. I think that was an excellent start of that second season of our training program. And I'm glad that so many of you assisted today and to see back some of your faces. I hope that we will meet during this year several times to enhance your work. That is very, very much needed. But I also want to thank you, Dr. Bulavinova, and also the office at the Cabinet of Ministers for their continuous support. This has been an excellent cooperation. Please stay all safe and see you next time. Thank you very much.
See you. Have a nice evening, all of you.
Bye-bye.
Bye-bye.